So, this is the title of my presentation. I intend to talk to you guys about non-stapling solutions treating obesity and diabetes. And on my way to here on the plane, I was thinking, what should you guys thinking about this in the audience? And the only thing that comes to my mind is, who is this guy who dare to talk about non-staple techniques in the house of staples? But I will humbly ask some moments of your attention to show you what is being doing and what we are doing outside these walls in terms of endoluminal approach for these matters. And thanks again for the fantastic work of Elliot and Robin that introduced us in the world of metabolic surgery. That makes me very simple task to talk to you about these two very cool words, that is globesity and diabesity. They were created by the World Health Organization to highlight what is coming to us. That is, when diabetes merge with obesity, creating the diabetes, we have the worst disease that we have ever faced off. And no matter how much we are able to treat this disease with medicines, with metabolic surgery, we still have a black, not a completely whole, but almost of 96% of unmet needs. That give us this graph. And this graph you can see here, before you climb the mountain, behavior modification, some drugs, exercise. On the top of the mountain, the morbid obese patients, we have the surgery. So can you imagine the huge gap of opportunity we have? Or to use that to keep those patients downhill as the lean patients, or the ones who are progressing to morbid obesity, to buy them some time, or even to the ones who are not going to accept surgery, and it's a lot of patients, to introduce them to a more invasive technology that is safe, and they can see that it's going to work for a while, and going to prompt them to accept a more advanced option on that. So this you have just saw is bariatric surgery. We basically alters and reroute the flow of the food, and we sparks some hormones on that way. So we have procedures that reduce the gastric emptying, procedures that bypass it, and a mix of those procedures in terms of metabolic. And it leads us to these results. So more than 50% excess weight loss, more than 20% of total body weight loss, at least 7 to 10% drop on BMI, and is a long-lasting effect, and had demonstrated during all these 40 years that is among us, that is safe on that. And this is a ground, the morbid obese patients, the high BMI, and this is the #1 option for the morbid obese. That is the bariatric surgery. That's always a but. We fail miserably in reach the patients that needs this option with just 1% penetration. And it's basically the same among all the countries that has this option. So let me introduce you to this novelty that is the bariatric endoscopy. And what we want when we grow, we want to be bariatric surgery. And you can see here on your left side of the screen, we have space-occupying device. On the middle of the screen, we have real endoscopic suture. On the right side of the screen, you have the bypass procedures. So it kind of mimics the slide the preview showed you about bariatric surgery. And bariatric endoscopy has a lot of tools. Some of them are about to come to US. So it's expected the FDA approve the intragastric balloon in the following days. And intragastric balloons have been used in any other country in the world besides US. So going to be the novelty here. More than 300,000 of those implants have been done worldwide. And the two that are going to be approved, if you cross the line, you're going to see the liquid filled balloon on the upper left, and then you're going to see the double balloon. This is the one that is considered to be approved in the US. But you have balloons that you can swallow. You have balloons that you can adjust, so there's a different rank. On the right side of the screen, what you're seeing is that an evolution of this, or maybe a different way to see that, is not just occupying the stomach and creating bumps around the proximal bowel. Those are in the first-in-human studies, and have to be studied more. In terms of suturing implications of the stomach, we are advancing a lot. From the very first generation machines, the actual generation is able to perform plications that can last up to 2 years and full thickness suture that can last at least 1 year. And believe me, that's a lot on my world. That we were restraining to 6 months results, now we're expanding to 1 year, maybe 2 years. And even more, on the right side of the screen, we dare to use staples in endoluminal. And that's the good news. We fail hard. But it's still some on that. On the middle, you have a linear stapler. On the extreme right side, you have circular staple. They're very, very elegant way to staple by endoscopy, but didn't progress. So this brief video will show you what we are actually doing in terms of suturing. So we can modify the stomach anatomy with a full thickness suture. And you can see here it looks like a needle holder. And we have a grasper in corkscrew-like, and we can modify this anatomy. Anterior wall, greater curvature, posterior wall, and we're going to suture in the old-fashioned laparoscopic, that is the knot pusher. Do you remember that? And then, in the fast-forward mode, you can see how we can adapt these. So, and we published our group published the very first series, and we have around 300 of those cases done worldwide with an FDA-approved device, not labeled to that. So they are doing the FDA trial now. And much more than I can show to you, than I have time to show to you. But very briefly, you can see here that we can dare in the middle to do a gastric bypass, meaning we bypass the stomach and the proximal bowl, and even we can offer you, and it's under FDA trial to be approved, the aspiration therapy. That means you can eat as much as you can, and then you go to the bathroom and aspirate that. That's ugly and nasty. But from the patient's perspective, maybe not. So yeah, it's safe. And what bariatric endoscopy can offer us? In a mean, no more than 50% excess weight loss. No more than 20 of total body weight loss. BMI drop between 5 and 7, we are very satisfied with that. But this is with a very, very good safety profile. And allowed me that joke, but it's very hard to kill people by doing endoscopy. We have been trying that for the last 15 years. It's not easy. But it lasts up to 1 year. And our target is lower BMI patients. So this gap from the very first graph I show you that we wanted to fulfill, and maybe we can help bariatric surgery or the other methods to treat obesity to raise the penetration rate. So, where we are right now, we are in between the clinical treatment and the surgical treatment, interfacing with both, at least for my reading on that. Metabolic surgery, as demonstrated previously, you see that if in bariatric surgery we reroute the flow, in metabolic surgery we have even more procedures that can reroute the flow of the food in such amount of different ways as you can see right now. In terms of endoscopy, the subset of bariatric endoscopy is we are creating the metabolic endoscopy. And now, at least with 2 devices, we have some experience that we can provide a bypass on the left, a duodenojejunal bypass, or even we can remodel the mucosa of the proximal bowel on that. There are some other devices. They are very fresh and new. They are on the first in human experience with very few cases. On the left, mimic the very first duodenal sleeve, and on the right, mimic A jejunal ileal bypass, an old procedure designed for obesity but can be used for metabolic with the benefits of the magnets and can be done completely by endoscopy. As said, two of this technology I want to present in some more